This is part 2 of FIGO 2025 update of GTN. If you have not watched part 1, then first watch it. Treatment in molar pregnancy. Conventional suction evacuation or manual aspiration in settings without electronic equipment remains the preferred method for uterine evacuation, ideally performed under ultrasound guidance. So USG guided suction evacuation is the preferred treatment, and the number of suction cannula used is 7 to 12 mm. IV oxytocin infusion may be started at the onset of suction curettage and may be continued for several hours post-operatively to enhance the uterine contractility and decrease blood loss. As we know, IV oxytocin infusion to give T-half of oxytocin is around 2 to 3 minutes. So we must start at onset of suction curettage. When available, hysteroscopic resection of residual tissue can serve as a complementary approach. That is, first to do USG guided suction evacuation, followed by, if there is any residual tissue, then to do hysteroscopy guided resection of that tissue. Because the risk of bleeding increases with uterine size, as the uterine size increases, the risk of bleeding increases. Blood for transfusion should be available when the uterus is greater than 16 weeks in gestational size. RH immunoglobulin should be given to RH negative women at the time of molar evacuation, as the RHD factor is expressed on the trophoblast. So if pregnant woman is RH negative, then to give RH immunoglobulin. A second curettage yields controversial results and should not be routinely performed. However, it may be used in selected cases with uterine bleeding and ultrasound findings suggestive of molar remains in the endometrial cavity. So after USG guided suction evacuation, if there is any retained tissue, then second curettage to perform. Otherwise, not to perform routinely. Second option, hysterectomy. It is an alternative to suction curettage if childbearing is complete. For example, a 45-year lady came with molar pregnancy and she does not want any pregnancy, so you can consider for hysterectomy. Along with hysterectomy, permanent sterilization to do. It decreases the need for subsequent chemotherapy by eliminating the risk of local myometrial invasion as a cause of persistent disease, because you are removing the whole uterus. Medical induction of labor and hysterectomy are not recommended for molar evacuation, as it increases maternal morbidity and the development of post-molar GTN requiring chemotherapy. So first is USG guided suction evacuation, second is hysterectomy, but medical induction of labor and hysterectomy are not recommended. Prophylactic administration of either methotrexate or actinomycin D chemotherapy in a molar pregnancy at the time of or immediately following molar evacuation is associated with a reduction in the incidence of post-molar GTN of 3 to 8%. That is, you do the suction evacuation and after that you give prophylactically either methotrexate or actinomycin D. So this prophylactic dose will decrease the incidence of post-molar GTN up to 3 to 8%. However, it should be limited to special situations in which the risk of post-molar GTN is much greater than normal or where adequate SCG follow-up is not possible. So when to give prophylactic administration of chemotherapy, that is of methotrexate or actinomycin D, when there is a risk of a higher risk of post-molar GTN or when the patient is denying for follow-up. In those special cases, you can give prophylactic administration. Don't give in all situations. Follow-up SCG monitoring every 1 to 2 weeks is essential for diagnosis of and management of post-molar GTN. If testing is carried out at 2 weeks interval and a rise or plateau in SCG level is detected, next sample to be obtained after 1 week. On the other hand, post-molar GTN rarely occurs after the spontaneous return of SCG levels to normal, allowing for a shortened follow-up period for most women. A single additional confirmatory normal SCG measurement 1 month after first SCG normalization is recommended for a partial hydrated deformed mole. So partial hydrated deformed mole, you did the SCG follow-up and it became normal, then repeat after 1 month. And monthly SCG measurement should be obtained for only 6 months after SCG normalization for a complete hydatidifform mole. So you will check whether it is partial hydatidifform mole or complete hydatidifform mole. After normalization of a beta SCG, do one repeat beta SCG after 1 month. Whereas in complete hydatidifform mole, you have to repeat beta SCG monthly for 6 months. This is the updated guideline. Hormonal contraception is considered safe during post-molar follow-up period to avoid the pregnancy. Termination of a pregnancy is not indicated if accidental pregnancy occurs during surveillance after SCG level has returned to normal. For example, a patient came to you with molar pregnancy. You did the evacuation and followed her. Beta SCG normal, her beta SCG level becomes to pre-pregnancy level, that is normal value. She became pregnant. In those cases, termination of pregnancy is not indicated. Recurrence in a later pregnancy, low, that is 0.6 to 2% after 1 molar pregnancy, although much increased after consecutive molar pregnancies. Mutations in NLRP7 and KST-C3L have been reported in women with recurrent molar pregnancy. This is autosomal recessive disease. During my residency in AIIMS, I have seen one patient with 4 molar pregnancy, and in 5th one she became pregnant. During that time we did her analysis of mutations, so she came as NLRP7 positive. So we diagnosed it as recurrent molar pregnancy. Coexisting normal pregnancy with mole. Molar pregnancy rarely coexists with normal pregnancy. Diagnosis is usually made on ultrasound. Although there is a high risk of spontaneous abortion, about 40 to 60% result in live births. The risk of GTN in coexisting molar and normal pregnancy compared with singleton molar pregnancy is increased from 15 to 20% to 27 to 46%. In the absence of complications and normal genetic and ultrasound findings, pregnancy can proceed. GTN. Treatment of GTN is generally by chemotherapy. GTD. In GTD, there is pre-malignant molar pregnancy or GTN. In GTN, there is invasive mole, choriocarcinoma, PSTT, ETT. Invasive mole and choriocarcinoma mainly chemotherapy, whereas PSTT and ETT mainly hysterectomy. The best regimen depends on stage and classification. In the 2000 FIGO staging and classification, a risk of 6 and below is classified as low risk, that is less than 7 is low risk. It can be up to 6, and above 6, that is 7 onwards, is considered high risk. Score more than or equal to 13 is considered as ultra risk. So risk assessment is low risk, high risk or ultra high risk. When the score is 1 to 6, it is low risk, 7 onwards up to 12 is high risk, 13 or more is ultra high risk. Next comes low risk GTN. Patient with low risk GTN should be treated with one of the single agent chemotherapy, that is either methotrexate or actinomycin D. We preferably give methotrexate. Chemotherapy should be changed to the alternative single agent if there has been a good response to the first agent but the SCG level plateaus or rises during treatment, or if toxicity precludes an adequate dose or frequency of treatment. So when to change the chemotherapy? For example, a patient came to you, you diagnosed her as low risk GTN and you give methotrexate. So after giving methotrexate, the beta SCG value falls, but during follow-up her beta SCG level plateaus or rises. This is a scenario. Second scenario, if there is methotrexate toxicity, then you have to change the chemotherapy, that is you have to change to actinomycin D. Change to single agent actinomycin D from single agent methotrexate gives a good response rate of between 76 and 87% in patients with relatively low SCG level. So this is MCQ. Chance of curative treatment is strongly related to the SCG level at the time when single agent actinomycin D starts. Superior efficacy of actinomycin D has been given by 2016 Cochrane review and a 2021 meta-analysis with a complete remission rate of 80% versus 65% for methotrexate. So which is more efficacious? Actinomycin D is more efficacious than methotrexate. Methotrexate around 65%, whereas actinomycin D around 80%. So why don't we give actinomycin D in most of cases? Because of the toxicity. Actinomycin D may also be associated with a higher incidence of adverse effect like some hair thinning, nausea and vomiting. Due to the toxic effect, even though it is superior efficacy than methotrexate, we don't give actinomycin D as first line agent. Approximately 30% of low risk GTN patients develop resistance after single agent chemotherapy. So resistance is of two types, primary resistance or secondary resistance. In primary resistance, it is defined as a rise or plateauing of beta hCG levels, but less than 10% decrease during the first two cycles. Whereas secondary resistance is defined as plateaued or rising beta hCG after initial effective treatment. So you gave methotrexate, it became resistance, that is beta hCG value rise or plateaus, then we diagnose it as resistance. So how to know whether it is primary resistance or secondary resistance? If the rise or plateau during the first two cycles, then it is primary resistance. Another is avelumab as a second line treatment for methotrexate failed low risk patients. Complete response rate is only 53%, which is less than methotrexate, disappointingly lower than second line actinomycin D chemotherapy. In actinomycin D it is around 80%, and it is not recommended as a standard salvage treatment in low risk cases. In low risk cases you can give methotrexate, you can give actinomycin D or avelumab, but avelumab is not preferred one. Patients with FIGO score 5 to 6 with metastatic disease, with choriocarcinoma histology or elevated pre-treatment hCG levels, that is more than 4,11,000 without metastasis or 1,49,000 with metastasis or choriocarcinoma, have an increased risk of single agent treatment failure. So in those cases, instead of single agent, you should start multi-agent chemotherapy. The remaining patients with FIGO score 5 or 6 are still best treated with 1 or 2 sequential single agents to spare women from the more toxic multi-agent treatment. For example, a patient came to you and you evaluated her and the score became 6. So till now we have studied that you can give methotrexate, actinomycin D or avelumab is not the preferred one, either methotrexate or actinomycin D. In practical world, methotrexate is given one, but you have to check 3 other things. Along with score 6, do you have any metastatic disease, or by histology it is choriocarcinoma, or there is elevated pre-treatment hCG levels without metastasis, or beta hCG level is more than or equal to 4,11,000, or with metastasis 1,49,000. Then instead of single agent, because it will lead to failure, instead of single agent give multi-agent chemotherapy. Higher risk score of 5 to 6 and clinicopathologic diagnosis of choriocarcinoma are both associated with an increased risk of resistance to single agent chemotherapy. We just read that. Lowering the threshold for the use of multi-agent chemotherapy in these otherwise low risk patients can be considered. In low risk disease, although hysterectomy is an option for select patients who have fulfilled their child with post-operative chemotherapy, will still be needed, as well as hCG monitoring, similar to patient managed exclusively with chemotherapy. As a result, hysterectomy is not highly recommended. So although the patient is low risk, you can do hysterectomy alone. After the hysterectomy, you have to do hCG monitoring and post-op chemotherapy. So hysterectomy is not highly recommended in those cases. After the hCG level has returned to normal, consolidation with 2 to 3 more cycles of chemotherapy will decrease the chance of recurrence, and the overall complete remission rate is close to 100%. You evaluated and diagnosed is at GTN, then you give methotrexate. Suppose after 7 cycle of methotrexate, her beta hCG value became negative, that is a pre-pregnancy value. Don't stop methotrexate right there. You have to give 2 to 3 more cycle of chemotherapy. First line single agent chemotherapy regimens for low risk GTN. So one regimen is methotrexate folic acid 8-day regimen. 50 mg of methotrexate intramuscularly on days 1, 3, 5, 7. Alternatively with folic acid 15 mg orally tablet 24 hours after methotrexate on days 2, 4, 6, 8. And repeat every 2 weeks. On day 1, she will receive methotrexate injection 50 mg IM. On day 2, she will receive tablet folinic acid 15 mg and after 24 hours of injection. On day 3, methotrexate. On day 4, folinic acid. 5, 6, 7, 8. Repeat those cycle every 2 weeks. Second regimen is methotrexate 0.4 mg per kg, maximum of 25 mg intravenously or intramuscularly for 5 days every 2 weeks. Third one is actinomycin D pulse, that is higher dose 1.25 mg per meter square intravenously every 2 weeks. Fourth option is actinomycin D 0.5 mg intravenously for 5 days every 2 weeks. Other option is methotrexate 30 to 50 mg per meter square intramuscularly weekly or methotrexate 300 mg per meter square infusion every 2 weeks. This regimen is more preferred, and in all situations folinic acid tablet is not available everywhere, so you can give injection, but this is the updated guideline. You can give folinic acid orally 24 hours after methotrexate injection. EMA-CO regimen is given in high risk patient. So regimen 1 and regimen 2. Regimen 1 to give on day 1 and day 2. EMA-CO, that is etoposide, methotrexate, actinomycin D, cyclophosphamide and vincristine. Etoposide, actinomycin D and methotrexate EMA is given on day 1. Instead of methotrexate, folinic acid rescue is given on day 2, whereas CO, that is cyclophosphamide and vincristine, is given on day 8. Dose is that etoposide dose is 100 mg per meter square IV infusion over 30 minutes. Actinomycin D 0.5 mg IV bolus. Methotrexate 100 mg per meter square IV bolus followed by 200 mg per meter square IV infusion over 12 hours. Etoposide and actinomycin D same dose. Folinic acid rescue 15 mg intramuscularly or orally every 12 hours for 4 doses, starting 24 hours after beginning the methotrexate infusion. Vincristine dose 1 mg per meter square IV bolus, maximum 2 mg. Cyclophosphamide dose 600 mg per meter square IV infusion over 30 minutes. The two regimens alternate each week, that is regimen 1 and regimen 2. This is week 1 and this is week 2. Salvage therapies. Instead of EMA-CO, you can give EP-EMA, that is etoposide, cisplatin, etoposide, methotrexate and actinomycin D. Second is TP or TA, that is paclitaxel, cisplatin or paclitaxel, etoposide. Third one is MBE, methotrexate, bleomycin, etoposide. VIP or ICE, etoposide, ifosfamide and cisplatin or carboplatin. Fifth one is BEP, that is bleomycin, etoposide, cisplatin. Sixth is FA, difluorouracil, actinomycin D. Seventh is 5, floxuridine, actinomycin D, etoposide, vincristine. Other is high dose chemotherapy with autologous bone marrow or stem cell transplant. 9 is immunotherapy with pembrolizumab. High risk GTN. Multiple agent chemotherapy regimens are used to treat. Most commonly used is EMA-CO, that is etoposide, methotrexate, actinomycin D, cyclophosphamide and vincristine. About 20% of patients do not attain complete response with EMA-CO therapy, but most can be salvaged with further therapy. The overall survival rates for patients with high risk GTN are now running as high as 96%. In low risk, it is around 100%. A number of adverse features predict poorer outcomes, including an interval longer than 2.8 years from the antecedent pregnancy, liver and or brain metastasis. The management of such patients, together with salvage therapy, ultra high risk gestational trophoblastic neoplasia, and salvage therapy. Among the high risk group, as defined by the FIGO staging and classification, a subgroup of score of 13 or greater, as well as patients with liver, brain or extensive metastasis, do poorly when treated with first-line multiple agent chemotherapy. For those with massive disease, starting with standard chemotherapy may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia and multi-organ failure, any or all of which can result in early death. To avoid this, the use of initial gentle rather than full dose chemotherapy seems logical. So if there is a case of massive disease, that is metastasis 1, and her score is high like 13 or onwards, If you give full dose chemotherapy, then there will be tumor lysis syndrome and that will lead to death. So instead of that, give gentle induction therapy. Induction: etoposide 100 mg per meter square and cisplatin 20 mg per meter square on days 1 and 2, repeated weekly for 1 to 3 weeks before starting normal chemotherapy, appears to have eliminated early death. For those patients with liver metastasis, with or without brain metastasis, or a very high risk score, EP, that is etoposide and platinum, or EMA, or another more intensive chemotherapy regimen rather than EMA-CO, may yield a better response and outcome. Instead of EMA-CO, you can consider EP-EMA in those liver metastasis, brain metastasis, or very high risk. For such high risk patients, a longer consolidation with 4-cycle chemotherapy should be considered. In patients with brain metastasis, an increase in the methotrexate infusion to 1 gram per meter square will help the drug cross blood-brain barrier, and intrathecal methotrexate 12.5 mg may be used. This can be given at the time of CO when EMA-CO is used, or with EPA in the EPA or EMA regimen. In case of a brain metastasis, some give whole brain radiotherapy 3000 centigrade in 200 centigrade daily sessions concurrent with chemotherapy, or use stereotactic or gamma knife radiation to treat existing or residual brain metastasis after chemotherapy. This is treatment when there is brain metastasis. However, there is no evidence that whole brain radiotherapy improves cure rates, and it does add to long-term toxicity. Therefore, it is not recommended in the recent guideline. Patients with resistance to EMA-CO are mostly salvaged with paclitaxel and etoposide, alternating with paclitaxel and cisplatin, or with EP or EMA. In China, the 5-fluorouracil based FET regimen is also an effective salvage treatment. When there is resistance to EP or EMA, or TE or TP, options include a number of other standard or high-dose chemotherapy regimens with autologous peripheral stem cell support. Checkpoint immunotherapies like pembrolizumab may also save women and spare them the toxicity of high-dose chemotherapy. Finally, the surgical salvage should not be overlooked. Role of surgery. Hysterectomy can be considered in uncontrolled uterine bleeding, although it can often be avoided with the use of uterine artery embolization. Minimal invasive versus open abdominal hysterectomy in patient with GTD appears to have comparable oncologic outcome, with less blood loss and shorter hospital stay in case of minimally invasive route. Laparotomy may be needed to stop bleeding in organs such as the liver, GI tract, kidneys, and spleen. Neurosurgery is needed if there is bleeding into the brain or increased intracranial pressure. The resection of an isolated drug-resistant tumor may also be curative. Role of radiotherapy. Radiotherapy has a limited role in GTN, except in the treatment of brain metastasis, although its efficacy compared with intrathecal methotrexate is controversial. Placental site trophoblastic tumor or epithelial trophoblastic tumor, both are less chemosensitive than choriocarcinoma. So hysterectomy, it is the primary mode of treatment in most cases, and surgery plays an important role in the metastatic disease such as resection of solitary long metastasis. If fertility preservation is desired, especially in a localized lesion, conservative management such as uterine curettage, hysteroscopy, resection, and chemotherapy may be considered. Fertility preservation is not suitable in diffuse lesion. In advanced stage, EPIMA or TETP can be considered. Interval between antecedent pregnancy of more than 48 months, that is 4 years, and or stage 4 disease remain the most significant adverse prognostic factors and are considered more informative than using FIGO scoring up for GTN. For atypical placental site nodule, if there is no visible residual lesion, conservative management is considered for fertility sparing. Otherwise, hysterectomy is recommended. After treatment of GTN, follow-up SCG monitoring every month for at least 12 months is essential for surveillance of relapse. Reliable contraception must be used throughout this period. Future fertility, pregnancy, and offspring are not affected, although psychosocial and sexual counseling may be needed for some patients. Thank you.